Good evening, everyone. Good evening.
Yeah, good evening, sir.
Good evening, everyone. I'm glad that Dr. Praveen also has joined us. Most welcome. We are on the air of the YouTube. We are on the air of the YouTube. I welcome all of you. Can all of you please unmute your mute your audio? I now request Dr. Puneet to take on.
Thank you, sir. I welcome you all to the ASI time, that is today's third Wednesday of this month. That is 16th of April 2025 at 9 p.m. And today in ASI time, we have How I Do It sessions, where we have a video presentations there from the eminent surgeons. And we are discussing about the tips and tricks for the safe esophageal anastomosis, the anti-reflux surgery, and low anterior resections. And today's session will be moderated by Dr. Tarun Mittal from New Delhi. Before we proceed, I request Dr. Praveen Shurvanshi, the President ASI, to welcome all the viewers and the speakers.
Good evening, everyone. Again, on behalf of ASI, I welcome you all for this special session that everyone loves watching is How I Do It session. And to it, the topics are very interesting, and it is covering very vast range from the cervical esophagus to the low anterior resection. So I'm sure with this galaxy of faculties and Torun, who will be moderating this session, is going to be a great feast to watch. And I'm sure that all faculties, they will not just share their skills or knowledge, but they will share the wisdom, because all these are very special areas where need to, have a lot of experience to master these areas. So I welcome all the faculties, and also I'm thankful for them for accepting our invitation and to share their knowledge and skills on this platform. Also, I thank all the viewers across the country. Every time we are, touching the record break participation for this ASI time. Last year, we were skeptical whether, this is working or not, whether we should continue this activity. But this year, the response from all the viewers across the country is very encouraging. So it's so all credit goes to all the faculties. They are doing a lot of hard works, and the team of of the academics at ASI head office under the leadership of Dr. Santosh. All their hard work is paying off now. So thank you once again, and I request Dr. Puneet to carry forward this session.
Thank you, sir. And I request Dr. Tarun Mittal, the Senior Laparoscopic Consultant Surgeons from Sir Gangaram Hospital, New Delhi, to please moderate the session. And he is a very active member of EC member of ASI from New Delhi and a very good friend of mine. So I request Dr. Tarun to please proceed with the today's session. He is going to introduce the speakers. Once we have a video presentation from all the three speakers, then the question answer session will be conducted. So over to Dr. Tarun.
Good evening, everybody. At the onset, I would like to thank the ASI leadership, Praveen sir, Santosh sir, Puneet sir, for giving me this opportunity. We have three gifted surgeons who would be speaking on various topics. First is Dr. M.P. Srijan. He's a HOD and Government Medical College, Kerala. Dr. Roy Patankar, who everyone knows, he's a Director General Multi-Specialty Hospital, and Dr. Faisal Perry, who is a professor and head colorectal division, SKIMS, Srinagar. So at the onset, I will request Dr. M.P. Srijan sir to speak on tips and tricks of safe cervical esophageal anastomosis. Over to you, M.P. Srijan sir. We will take the questions in the end after all the three talks have been done.
Yes, thank you, Dr. Tarun. Very good evening to all. Good evening, Praveen sir and Dr. Santosh John Abraham, Dr. Praveen Suryavanshi, Dr. Puneet, and Dr. Faisal, and all those listening in the YouTube. And I'm going to talk about a safe anastomosis of esophagus with the stomach and the neck. Esophageal anastomosis is a critical step in esophagectomy. Prevention of leak and strictures are the two most important aspects of it. Most of the time, because of the complications.
Again, we cannot see again, Dr. Srijan, we cannot see your video.
Okay.
Yeah, it's fine.
Yeah, okay. So there are a lot of factors involved in the success of an esophageal anastomosis. Starting from the patient selection, optimization, and we have to address the comorbidities, correct the nutritional aspects, and we have to rehabilitate the patient for a successful outcome. I have to thank all these great teachers of mine who has helped me to climb the ladder. And surgical techniques are very important in every aspect of surgery, especially in esophageal anastomosis. The basic things which are required are the tension-free anastomosis. The vascularity has to be very good, and the lumen has to be adequate, and a very good technique has to be used. But of the lot, what I consider always is that gentle handling of the tissues, especially the stomach, is one of the key factors to prevent further complications. The anastomosis can be created with several techniques. That is, end-to-end anastomosis can be made, or end-to-side anastomosis, side-to-side anastomosis, and again, sutured anastomosis, or interrupted continuous sutures, staple, that is posterior stapling, or anterior and posterior stapling also can be used as a technique. With all the technical issues, complication can be prevented by meticulous surgical planning, execution, and attention to detail in every step, including anastomosis. Here I'm going to start with the incision. The best incision which can be made is a crease incision in the neck. Some of the surgeons use an oblique incision anterior to the sternomastoid, but cosmetically that is not a very good incision. The best incision would be a crease incision. And access to deliver out the esophagus and to make the anastomosis, it is not a problem at all. We will be able to get access and we will be able to reach the prevertebral plane. And there is no difficulty with this incision. The healing is much, much better. So the cosmetic aspect also is considered here. Otherwise, the patient is going to have a long oblique incision on the anterior aspect of the neck. The flap is made upwards up to maybe for about 5-7 centimeter flap can be made. And usually the lower flap is not taken. Now you can see the division, the two heads of sternomastoid, the sternal head and the clavicular head can be seen there, and I am going in between and we will be reaching the carotid sheath directly. But instead of that, we can go in the anterior aspect, that is the anterior to the sternomastoid. And we require more traction or more retraction when we use that. I always find that between the two heads of the sternomastoid, it is very easy to reach the prevertebral plane. The only one structure which is crossing at this point is the omohyoid, and the omohyoid can be divided here. And a portion of the omohyoid can be taken out also, so that we get adequate space there. And once that is divided, we will be reaching the strap muscles there. The sternothyroid and the sternohyoid will be seen there. And then we will be able to go medially. You can see the carotid sheath and the jugular vein there. And then anteriorly, you will find the carotid artery. And I am dissecting the plane in front of the carotid and reaching the prevertebral plane. The next thing is, we are going to encounter one vein, that is the middle thyroid vein. You can see the middle thyroid vein. And we have to either cauterize or ligate this vein depending upon the size. And I have not edited this video at all. You can see the inferior thyroid artery there. And sometimes it is very difficult to deliver out the esophagus. It will be on the other side. I have made an incision on the left side of the neck. And sometimes it is very difficult, and we can find out or palpate the nasogastric tube inside the esophagus. And we will be able to mobilize the entire esophagus and we can take it out from the prevertebral plane. If we introduce an instrument on the vertical direction, we know that the trachealis muscle is there on the posterior side and it can injure the trachealis and the tracheal bulb might come out. So always care should be taken to prevent injury to the trachealis muscle. And also we have to identify the recurrent laryngeal nerve there. And if we go too far on the right side, sometimes actually we can pull the recurrent laryngeal nerve from the other side also to the left side. So utmost care should be taken to safeguard the recurrent laryngeal nerve and to safeguard the trachea at this point. Now my finger has gone to the medial side and my instrument is going from the posterior side and the esophagus is isolated. And with the help of an umbilical tape, we will be able to hold it and we can retract this. Further dissection will be, I'm using an umbilical tape to hold the esophagus here. In this picture, you can see the recurrent laryngeal nerve. We have to deliberately identify the recurrent laryngeal nerve because the recurrent laryngeal nerve supplies to the cricopharyngeal area here. And damage to the recurrent laryngeal nerve actually can cause dysphagia and sometimes aspiration. And so the patient will come with dysphagia and the patient will go back with dysphagia. That is the problem. So in all cases in the tracheoesophageal group, before we isolate the esophagus, we have to identify the recurrent laryngeal nerve and safeguard it here. And next, part of the dissection can be done from the neck. That is, with my finger, I am dissecting the posterior aspect of the esophagus. And one thing is important here, the pad of the finger should be directed towards the esophagus, or we should hug the esophagus and move. If our pad of the finger goes to the medial side, then there is a possibility for injuring the trachea. So always take care of the trachea by keeping the index finger away from the trachea, or to avoid injury to the trachealis muscle, our pad of finger has to be on the lateral side or close to the esophagus, or hug the esophagus and move on. So part of the mobilization can be done from here, but mainly if it is thoracoscopic, we will be able to reach up to this area without any difficulty. You see in this picture, you can see that the trachealis muscle is injured. And once it is injured, the tracheal bulb or the endotracheal tube bulb will just come out and it will completely deliver out. And we will have to spend another 1 hour to suture the trachea. So here I have mobilized the entire esophagus and maybe 4 to 5 centimeters of the esophagus from the cricopharynx is used for the anastomosis. And the nasogastric tube will be inside and it has to be pulled. Ask the anesthetist to pull the nasogastric tube. An incision is made in the muscle and never cut at the same level, because if we cut at the same level, the mucosa gets retracted. I'll show this in the next slide. So I have divided the esophagus from here. And always cervical esophagus and the upper thoracic esophagus is treated by radiation. So a margin of clearance of 10 centimeter in squamous cell carcinoma is the best option for any patient with squamous. And here you can see the division of the esophagus and the retraction of the mucosa. I have divided the muscle and the next division is taking place at the mucosal area. Now you can see that the mucosa is getting retracted. At least 0.75 to 1 centimeter of the mucosa should be there. Otherwise, it will retract and it will go beyond the muscle level. And the most important layer in esophagus is the mucosa and the submucosa. We are not going to take the entire stomach, but this is just to show that it's a very well vascularized stomach. Always Professor Mark Bioringer used to say, pink in the abdomen and pink in the neck. So if we keep 3 branches of the right gastric artery and the right gastroepiploic artery to serve the stomach. And each time when we handle the stomach, petechial hemorrhages occurs, and the submucosal vasculature is the main supply from 50% or almost up to 50% of the area. It is directly supplied, and above that, it is not direct supply, it is submucosal vascularity. So each time when we hold the stomach, there are petechial hemorrhages developing at that area, and that will definitely add to the complications. A 4 to 6 centimeter diameter stomach is tubularized and it is transported to the neck. And if stomach is not available, we are going to use the colon. You can see how stomach tube is created. Usually the first stapler for about 3 centimeters is applied at the incisura, keeping 3 vessels from the right gastric artery. And the stomach tube should be a uniform parallel stomach. And once the incision or once the stapler is applied at the incisura, the stomach becomes straight. And after that, we will be able to use a 20 centimeter stapler to complete the tubularization. Maybe 2 10 centimeter and 1 5 centimeter will be enough for the creation of the stomach tube. And cauterization is not a must. And if the anastomosis is going to be in the neck, there is no need to cauterize. But if you think that the length is not adequate, then we will have to cauterize. Otherwise, if there is a pharyngeal anastomosis, probably we can cauterize and we will get another 5 to 7 centimeter extra. So now we have made the esophagus available and the stomach tube. And now the stomach tube is transported to the neck and then the anastomosis begins. Now you can see this is the neck area. You can see what is seen on the right side is the esophagus, left is the stomach tube. And the posterior part of the stomach and the posterior part of the esophagus is anastomosis. That is the posterior part of the esophagus, and that is the posterior part of the stomach. The creation of the anastomosis is between these two first. A posterior stapling and an anterior suturing can be done, or both anterior and posterior stapling can be done. The problem with an end-to-end anastomosis or an end-to-side anastomosis is the lumen need not be adequate, and that can produce stricture in the anastomotic site, and it will be a problem for the patient throughout his life. Frequent dilatation is required, and it's not a pleasant thing. So now I have applied 2 stay sutures in the esophagus. Now I'm going to put the stay suture in the stomach on both sides. The upper part of the stomach need not be utilized. If the length is less, we can utilize that. Otherwise, the topmost portion of the stomach need not be utilized for anastomosis. But there is a possibility for some vascular compromise at the upper part. So it is better that we use a few centimeters below if the length is adequate. Now the stomach is opened and the suction is put inside so that whatever content is there inside is aspirated or sucked out. And now the stapler is applied there in the stomach and the esophagus. Maybe 4 to 4.55 centimeter of the stapler can be utilized, because 1 centimeter will be lost when we use the anterior stapling. This is the posterior stapling. Posterior part of the stomach and the posterior part of the esophagus is now anastomosed. This is what we are going to create, the posterior and posterior. And adequate room will be available for the anastomosis. Now you can see the stapler is in place. And always see that there is no rotation of the stomach. You can see the sutured end. I always suture the stomach and divided end in open procedures. But laparoscopy, we don't do that. You can see both sides, the stay sutures are there, and the staple can be seen inside. There is no bleeding. It's a wide room available for the anastomosis. So there is no question of stricture there. Generally, when we use continuous sutures or interrupted sutures, the ischemia which can develop is around 15%. And for continuous suture, it is around 25%. And for a stapler, it is around 40%. Still, the vascularity is good and the anastomosis can do well. There won't be any problem with the anastomosis. You can see the color of the stomach, that is well vascularized. The stomach and the esophagus is well vascularized. It is pink on both sides. And 2 stay sutures are placed on either side. The posterior layer of the stomach is now taken. So in the central part, there is 1 suture on either side. Each side, there is 1 stay suture. And the whole thing will be lifted up, and maybe 0.5 to 1 centimeter of that area can be utilized for the anterior stapling. Now, I'm going to place the stapler. And usually I use a 75 or 80 stapler here. 55 won't be sufficient. For the other first posterior stapling, 55 is enough. Maybe 4.5 to 5 centimeters is used. Here, always use a longer one like 75 or 80. Now the stapling is over. you can see that there is a perfect anastomosis there, and the edges can be oversewn or the corners can be sewn with silk, or that is not required in most of the cases, but I always do that. And the anastomosis is just pushed into the neck area. It will not go into the thorax because the esophagus which is taken is mainly from the cervical region, and maybe part of this anastomosis can go into that area. So that completes the anastomosis, and it's always better to go for a stapled anastomosis. I've been doing it for the last 15 years, and I've stopped all the sutured anastomosis, continuous interrupted, and end-to-end and all those things. So a successful esophageal anastomosis requires meticulous planning and execution, attention to detail at every step, and proactive strategies to prevent and manage complications are required. Minimizing leak and strictures are crucial for reducing postoperative morbidity and improving the outcome for the patients undergoing esophagectomy. Thank you very much. Thank you, ASI.
Thank you, sir, for wonderful video demonstration of esophageal cervical anastomosis. We will be taking the question in the end. I request Dr. Roy Patankar, sir, to give his talk on anti-reflux surgery.
Thank you, Tarun. Can you see my video and hear me clearly?
Yes.
Excellent.
We can. Yeah.
Thank you for asking me to speak on a topic that is close to my heart. I've been now doing anti-reflux surgery for about 27 years. And the surgery that I perform today is very different from what I did in 1997 when I began this journey. Quickly, to show you the anatomy of the diaphragm, it's important to see the position of